Hello and welcome to the back pain programme for the North East North Cumbria. I am Victoria Strassheim and I'm bringing you this in conjunction with Dennis Martin from ARC. So let me explain a little bit about what this event's about. So for those of you who aren't aware, the Academic Health Science Network is one of 15 agencies across the UK. We've been involved with the evolvement and adoption of the Spinal Pathway since 2016. We are a trusted broker across organisational work and we support economic growth, patient safety, quality improvement and population health. Dennis works for the Applied Research Collaborative and they are an agency that spans 6 universities, NHS, social, healthcare, community and voluntary sectors with the aim of delivering better, fairer healthcare for all. And with that in mind, we've come together to try and see if we can help physios and healthcare professionals address the issues of back pain and opioids in the region. The Spinal Pathway was created and developed in the North East. It's since been adopted by the NICE guidelines, but we're not quite sure how far it's been adopted across the region, and we suspect that's an issue nationally as well. 32% of people with back pain are prescribed opioids, and that's a huge issue in the North East alone. And Sue from the Academic Health Science Network is going to come and speak about the CROP project to try and help alleviate that issue. So what we'd like to try and do today is gain some stakeholder buy-in. We'd like your support to try and standardise the back pain pathway, the way osteoarthritis, hip and knee provision was standardised with escape pain. And what we understood there was that there was provision everywhere. There was excellent care in different areas and good practice to be learned. And we suspect the same things we're gonna see here, that there's some really excellent work being done, but is it being joined up? And that's why we ran the survey, particularly because of the COVID situation. I couldn't get out to see you all. And it's lovely to see such familiar names waiting in the lobby. So it's been lovely. And I'm just so sorry we can't all be together, but let's see what we can do today. So hopefully by the end of it, we can get some buy-in from you to help support this work. So the agenda is, next slide, please. We've got Ewan Moore talking about Painkillers Don't Exist, a public health campaign that's been run in Sunderland and Durham. We've got Cormac Ryan from Teesside University talking about the Flip and Pain campaign, another public health campaign. Then we've got Sue, as I've mentioned, from AHSN talking about the campaign to reduce opioid prescription. We've got Mike Hurley up from, or being beamed in from HIN in London to talk about the Escape Pain programme and the Joint Pain Advisor role, a Backcare programme. And then we've got Esther Williamson from Oxford to talk about the cognitive behavioural skills to treat back pain. That's the BEST programme. So 2 different or quite different approaches to dealing with back pain there. We'll hopefully stop if we're on time at 3:30 for a comfort break, then be back 15 minutes later and we'll run through the workshops. The scribes in each of the workshops to collect information so we can share all of the information from all the workshops with you following the event. Then please come back after that so we can discuss what happens next, run a few more polls, and then thank you. So we'll be running polls throughout the event so we can try and inform what we already know or what we think we already know. Please use the chat if you've got that facility to realign my understanding. If you think what we're saying, what we've understood is incorrect, do let us know. It's been really difficult to try and get a really good understanding of what's happening on the ground. Next slide, please. So this is the issue. 34% of adults have got chronic pain. We know it gets worse as people get older. It gets worse with increased BMI, and it gets worse with decreased activity. We know of that 34% of people with chronic pain, that pain is felt in 42% of them in the back, and that's the issue that we want to try and help support. It's a tricky, difficult, complex issue. Next slide, please. Thanks. So, as we've said, in 2016, the Spinal Pathway was rolled out in the region. Since that time, it's been adopted by NICE guidelines. How it should look, and no doubt it looks different if you travel over a hill or across a river, because that's what we found with escape pain. Provision looks different depending on where we are, because physios and healthcare professionals are resourceful and they use what they've got to give the best care they've got. So patients attend with a back pain problem. They are assessed for red flags. Those red flags are dealt with. If they are then stratified using something like the Start Back tool. And what we know, so the Start Back tool, if everybody is aware of that, is a tool that stratifies patients depending on their likely outcomes. So they fill in the questionnaire, an outcome is decided, and they go follow that pathway. So that could be group exercise, a little bit of advice if they've got quite good outcome likelihood, manual therapy or psychological therapy if the moderate light outcomes. But for those more treatment resistant patients, it's a combined physical and psychological program approach. And that's what we're starting to look into now. So now if we could have the next poll. So if you look in your chat, Sarah's going to pull up a poll in the chat. And the question is your service delivering the pathway the way you would like it to? And if it's not, if you could in the chat, let us know why isn't it? Thank you. So if you could, again, we're starting to get people coming through, let me know why it's not being used. So we asked the question in the survey, what are the obstacles? What are the obstacles to treating people with back pain? And what came back was the messages that came back were, it sounded like the issues were the people who fall into the more treatment resistant pathway, and the low mood, fear, pain avoidance, biopsychosocial issues. And another big one was the communication, consistent communication across the pathway. Can I have the next slide, please, Stuart? So in summary, this was the last few comments that were made, and that just absolutely summed it up. Expectations of the type of treatment, revolving door patients, and the lack of joined up approach from primary to secondary care with regards language used. So now can we have the second poll? The question I would like to ask is, are physios and patient expectations in alignment? So are physio and patient expectation of what Spinal Pathway can deliver in alignment? And if you could respond to that, I'll give you a few minutes to respond to that. Oh, has that come back very quickly? And then if you could, if you want to elaborate on that, please do so in the chat. Is it that there's a paradigm shift needs to happen, a change in perspective? So this is a slide that's come from Dermot Ferguson. So Dermot's here today. He's a physio from Northumbria, and he is the chair on the UK Specialist Spinal Board. And this is where we need to be moving from and to. We need to stop offering a fix or a cure and start providing more of a plan. We need to be more empathic and honest and empower the patients to provide or to create their own plan and management. And when I saw this slide, it rang true with me. So I work clinically as a fatigue physio on a Monday morning. And can I have the next slide, please? And I could see myself in my cubicle with my patients being in the dreaded drama triangle. And I don't know if you've come across the drama triangle, but I've worked with a lot of psychologists now, and I sort of pick up general bits and pieces. I'm no expert, but I could really see myself here. I can at times act as the rescuer to my patient who is the victim, and I want to rescue them from their situation, and I want to help them. But if my language isn't right or correct or appropriate for that person at the time, I can very quickly turn into the persecutor. Oh, and it's happened so many times. I'm really exposing my soft underbelly here. but I'm sure we've all been in that position, and it's a really uncomfortable place to be. And it's that place where you break down that lovely therapeutic relationship that you're trying to build. And I am trying very hard to become more of the coach, that sensitive challenger to my patient who is going to be the creator of their own management plan, depending on what skills they have in their biopsychosocial circle. So I don't know if that resonates with you. If it does, please let me know in the chat. So let's see what else we can say. So can I have the next slide, please? So in my capacity as a fatigue physio, I also do some research, and I've been reading a lot, and this rang so true for me. And I can, from what I'm hearing, I'm speaking to people, I can see there's a cultural change that needs to happen, because culture is going to be what prevents the strategy from changing. Well, this is what we've always done. Patients have always expected. The patient comes in, I expect a cure, and we need to start changing that. And how do we go about doing it? We sit in a biomedical model, and we're trying to deliver biopsychosocial healthcare. And sometimes that creates a clash of expectations between the patients and the healthcare provider, and creates almost a defensive position that we need to try and break down. So this is something that I really recognised from my fatigue life, and I wondered whether or not it was something that spinal physios recognise too, that sometimes you feel really vulnerable in that cubicle, knowing there's a miscommunication there, and how do we address it? Next slide, please. So this is another Dermot slide, so thank you very much, Dermot. Our patients arrive through our door and they're cooked. You cannot separate the social, the bio, and the psychological issues they've got. They come together as a whole, and we need to treat them as a whole. But we have been trained, particularly if you're my age, and I'm very old now, I was trained in a biomedical model. You identify the problem and that's what you treat, and you forget about everything else. And we know that's not the case now, but we still are delivering healthcare in that biomedical model. And what can we do to change that around? How can we change? What do we need to do? Next slide, please. So the results of the survey, 26 people responded from across the region. We had 8 of the 9 localities respond. Mostly physios, but we do have a doctor and a pharmacist in the audience, so hello and welcome. We did have a public health practitioner respond, and this is what they said. Next slide, please. So the use of Startback is across the board. Everybody's using it, which is great. The research says there's a £225 return on investment for every pound spent on the Startback tool. But I've got some questions there around, is that only as effective as the service and the pathways we've got, the services we've got within that provision? And if we haven't got enough provision for the treatment-resistant patients, are we still getting that return on investment? Next slide, please. So what we're delivering service-wise within each region, it's pretty comprehensive. There's lots of manual therapy, there's lots of individual one-to-one exercise, CBT, motivational interview techniques in one-to-one and in group sessions. There's exercise groups being delivered in groups, one-to-one for general and back pain, education groups, combined education and exercise groups in some areas. There's signposting into the community, there's exercise on referral. So we are pretty much well served. I've got a question here that if you could answer it in the chat, I'd really appreciate it. What I don't understand is it that people who come through who are scoring high on the Startback tools, do they get referred directly into pain services? And is that where those patients are treated? Or are they initially treated by the MSK physios? It was a question I didn't even know to ask at the beginning, so I didn't. So I'm hoping that might come out today. If you can enlighten me, that would be great. Next slide, please. So I've asked the question about confidence to discuss opioids and employment for 2 reasons. So for opioids, we know it's an issue. We know that it's a massive issue in the Northeast. But what we also understand is that 100% of the people who responded are saying people with on opioids, but it doesn't look as though people are particularly, or physios are particularly confident at starting that conversation. And I just wondered why that was. Is it that there's nowhere to refer patients onto, so what's the point in having the conversation? Or is it that there's a training gap there that we could possibly help fill to increase confidence? The employment question was, I suspect that the small and medium enterprises probably don't have access to occupational health and human resources, so they're probably going to come through the doors of the NHS musculoskeletal services. So will they have the same or some signposting to what a reasonable adjustments at work would look like, and do they have that employment support? And if they don't, I'm not necessarily saying that we as physios need to become the occupational health experts, but could we somehow signpost them just with a little bit of knowledge, signpost them to certain places? Next slide, please. So referral options, pretty well served, particularly in County Durham, Newcastle and Gateshead. But again, 100% of the respondents answered that they saw patients on opioids. We have 4 localities out of the 8 that have access to the opioid de-escalation services. We have 3 to addiction services. And so is that one of the reasons why the conversations aren't starting around opioids? Because there's nowhere to send them to. But if this is an issue across the region, it's an issue for everybody. And is that something that we as the HSN should be helping with? We have 2 areas where they've got access to employment support. And again, we want to keep these patients in employment. If they're out of employment for more than a year, it's unlikely they're going to get back into it. So it is really quite important that we try and support employed patients to stay there. And how can we do that? It's a really, really big ask. Next slide, please. So thank you for listening to me. I hope that's drummed up some interest and some questions. Ask me questions and really feedback to me. So the next speaker is Ewan Moore. He's the Head of Medicine Optimisation and Sunderland Clinical Commissioning Group, and he's going to talk to us about the public health campaign, Painkillers Don't Exist. Thank you, Ewan.
Thanks very much, Victoria. I'll just assume that people can hear me unless somebody tells me otherwise. Yeah, thanks. I thought that introduction was excellent because I think it really the system doesn't necessarily facilitate joined up working across pathways, professions, organisational boundaries and that sort of thing. So I think it's really important that we have events like this where we see it from other people's perspective. And that's the first time I've heard this described from a physio's perspective. And actually, there was so much in there that I could take away from it. So I'm hoping that in the audience of largely physios, there's something we can take away from a pharmacist's perspective. So just a bit of background. My name is Jane Mullen, Head of Medicines Optimisation at Sunderland CCG. I'm a pharmacist by background, worked in various different acute trusts, mental health, currently working in CCG. This campaign was initially a Sunderland CCG campaign, since been adopted by County Durham in our neck of the woods, but also in Leeds. And there's some stuff happening with other CCGs elsewhere around the country. So if I can have the next slide, please. So the Painkillers Don't Exist campaign is a campaign that we developed in conjunction with a social marketing firm called Magpie. And it came from, it's one of a number of initiatives. We recognised, and I'll show you in a second where our opioid prescribing figures are, but we recognised that we were significant over-prescribers of opioids by comparison to other demographics in other areas that were like us. So we put in place a number of initiatives, and this is just one of them. We had previously worked with Magpie on different campaigns about antibiotics and other things. We really liked their approach of they were very proactive, very keen to be quite bold, quite supportive of the. We wanted to do things differently from a normal NHS campaign. So what we recognised was that our opioid prescribing was very, very high. The UK is not currently in the same position as the US, but it really is an epidemic, and it's catastrophic levels. In America, you're more likely to die from an opioid overdose than you are from a road traffic accident, which is just horrendous. But we recognise that if we don't do something, we're heading in that direction. So the point of this campaign is absolutely not to say that we in Sunderland or in County Durham have this sorted, not by any stretch of the imagination. There's a very, very long way to go. But it's hopefully to give a pointer towards the approach that we've taken, why we've chosen to take it, and what we aim to continue to do with it. But of course, this isn't just a prescribing problem. It's much, much wider. So I'll mention at the end about how we take it out of just purely the prescribing arena. Next slide, please. So a lot of this will come as no surprise to you. You'll know about the side effects of chronic opioid use, and all the more recent evidence about the lack of efficacy of opioids when they're used beyond 90 days as well, and particularly at high doses. But as I said, this isn't just a prescribing problem. If you look at opioid deaths, that chart in the top right-hand corner, we have much, much higher opioid deaths than anywhere else in England. Now, you can explain some of that away with demographics and history of heavy industry and all that kind of stuff. But actually, are we that different? If you look at the graph at the bottom, those two red lines, I appreciate it's a very small graph. Oh, sorry, can we have the next slide, please? I beg your pardon. Sorry, that's the one we should be looking at. Yeah. So those two red lines at the bottom, I appreciate it's quite small, but those two red lines there represent Sunderland and County Durham prescribing of opioids by patient number. So we are absolutely the top two highest in the country and quite a distance above everybody else as well. There's a little group of us that are up particularly high. So prescribing of opioids is a problem for the patients that we prescribe them for, but it's a much wider societal harm as well. It's not just about the fact that opioids make it harder to live a fulfilling and productive life and take on work and that sort of stuff. It's also the risk of diversion. And we know that there are significant levels of diversion of these prescribed medicines. So if we're looking to tackle that wider societal harm, then we need to reduce the amount of opioids, the legitimate opioids that are getting into the system. So there's definitely around the Northeast cultural issues about prescribing and about use. But I think there's definitely something about the systems, the processes, the pathways, influences from secondary care, pain clinics. It's that biomedical model that Victoria described that is no longer, we recognise now it's no longer the right way to treat pain. So what we wanted to do with this campaign was something a little bit different. We wanted to, rather than have lots have been done around a push from prescribers. And so there was a push from prescribers to contact patients who were taking opioids and to seek to engage them in conversations about reducing and so on. What we wanted to do was to shift that and make that a pull from patients. So we wanted patients and patients' families and friends and people around them to recognise the harm that these medicines were doing to them, the wider harm, and to begin the conversation that way. So we wanted to flag up that actually you may be living with pain, but the side effects of the opioids may be considerably worse than the pain. And interestingly, I noticed a lot of the content in the chat box earlier was about patient expectations and the need for a cure. And I think in the past, opioids were seen as a cure. They're absolutely not. And we know that now. We know that the harm is often worse than the pain that was there initially. So if we can have the next slide, please. So this is a little summary of some of the facets of our campaign. So we worked with a lot of stakeholders to develop this campaign. And painkillers don't exist as quite a broad statement. And we always kind of added the caveat that this doesn't include cancer, it doesn't include acute pain. So we were talking about chronic pain, and we were talking about long-term use. So we wanted to really kind of hit people square between the eyes with this message about painkillers don't exist. And you can see some of the graphics and things that were on the website, and some of the stuff that we used was really quite stark, the colours deliberately so. We designed it with lots and lots of stakeholders and went through a number of versions, and this is what we settled on. One of the reasons why I said it wasn't a traditional NHS campaign was because we tried to get lots of innovative ways to showcase the message. So you can see the picture there. There was sand art done on Seaburn Beach, so a massive big sand mural, I think it was called, but painkillers don't exist, which obviously got a fair bit of local media interest. And actually, do you know what? Those things are not particularly expensive to do, but they get a lot of media interest, and it generated a lot of buzz and a lot of discussion. One of the side effects of a campaign that is as kind of bold and hard hitting as this is that the response is not always positive. But we were okay with that because actually it generated a conversation, and quite often the people who had the most negative response were the people that we were most trying to impact, the people that we were most trying to affect. So it got an awful lot of media interest. So we had the national BBC 6 o'clock news, 5 Live, Radio 4, The Times, Time Teas, all sorts of people showcased this and interviewed us and talked about the effect of opioids and the effect of painkiller addiction. We did that using certain hooks, like for example the draft NICE guidance that came out, that's due to come out in a final version quite soon about chronic pain. When that was launched, that generated a fair bit of discussion. One of the advantages of working with Magpie was that they had people who were kind of constantly on the lookout for this, and so when something like that happened, they were right on it, and they'd be putting out press statements, they'd be using all of their contacts. So we got really good coverage of it, and the most effective part of that, certainly in feedback from patients, the most effective part of that was the patient stories. So you can see there's a couple of quotes in there, reference to Stephen's story. We found that was the most important thing. So when you've got people who are on high dose, dangerously high dose, problematic opioids, hearing that there are people like them who have been through it and have come off it was very important. And also not treating these people in the same way that we treat the more traditional, in inverted commas, drug abusers, not people injecting heroin and so on, because that was quite often the only route that was available to people who were addicted to opioids. We needed to recognise that if you're going to tackle the addiction, you need to tackle the reason for the addiction and the background and the history. And so we felt some of those stories showcasing lots of different people in lots of different situations, ages, demographics, causes, all that sort of stuff was very powerful. Next slide, please. So there was a theory behind this as well. We were very keen to not just do a comms campaign for the sake of a comms campaign. So we worked with the University of Sunderland and used the COM-B model. And you can see there we've highlighted the particular behaviours that we wanted to intervene with. So there was some targeted towards patients, there was some targeted towards prescribers. So we wanted to what we felt was the more that we had this pull from patients contacting their GPs or contacting their services and saying, actually, I'm starting to think that the side effects of my opioids are not worth it, or I'd like to think about reducing, or I'd like to think about coming off. That gave those prescribers a chance for some reflective motivation. So there was that part. There was also obviously an educational part to it. We had a resource pack which we sent out as well. So there was a number of different things we did to try and influence particular behaviours. Next slide, please. So the impact. Now this graph doesn't look quite as impressive as it perhaps might do, but what it says we're turning around an oil tanker here, and that is a very, very slow process. So the number of things that we did is worth probably just covering off the broad range of interventions that we made. So first thing that we made available was an opioid resource pack. So that was information for prescribers, pharmacists, patients, community pharmacists, all sorts of different people about how to recognise problematic opioid use and how to go about reducing. So, what were safe ways to reduce, what were, interval periods, all that kind of stuff. That had very little effect, if any, on its own. The next thing that we did was put out an opioid position statement. And it really, in some ways, that didn't say anything new because it was reinforcing what was already there in national evidence and what was already recognised by people who understand these sorts of problems about the lack of efficacy and the lack of evidence. Now, what that did do, though, was we as a CCG said we do not support prescribing of or non-evidence-based prescribing of opioids, and then went on to list what we meant by non-evidence-based prescribing of opioids. That was very well received by a lot of our primary care prescribers because, to put it bluntly, they felt as though they had somebody else to blame. They felt as though they weren't sitting in front of the patient saying, I think you need to come off these. It was, the CCG says I'm not allowed to prescribe you these anymore. And that just started that therapeutic conversation off on a slightly different footing. So that therapeutic relationship between the patient and the prescriber was really, really important. So that had a kind of a reasonable impact straight away on its own, but doesn't necessarily have longevity. So you can see there then when the Painkillers Don't Exist campaign came in and when it ran, it's a more gradual reduction, but it's been sustained and it's continued to reduce. And we're still not talking huge amounts. We're talking about 0.68% reduction versus 0.18 nationally. So it's still not huge amounts, but it's significantly more. Considering everybody is doing something about opioids, it felt like some sort of success. The most important figure for me, though, was that we saw significant reduction in high dose. And so that's people who've taken more than 120 milligrams of morphine or morphine equivalent a day. That number reduced by over a third. So that's, put it in context, that was down from 900 patients in Sunderland down to fewer than 600 patients. So that's 300 patients in Sunderland who are no longer on those really high dose, really problematic, really dangerous levels of opioids. So that doesn't necessarily have a massive impact in the overall figures, but actually for those 300 people, that's a really, really significant change. So that to me felt like the biggest success out of the campaign so far. And if we can have the next slide, please. So the next steps, what do we want to do with this next? As I said, we're turning around an oil tanker here, so this is not something that's going to happen quickly. It's something that we want to continue doing for a long time. We are going to refresh and relaunch it again for this next, for 2021. It's when we expect the new NICE guidelines, so there'll be more interest around then. There will also be new evidence-based guidelines that we can refer to, and that will hopefully give us a new opportunity to start that conversation both with patients and with prescribers. But the other thing that we've done is consider introducing gabapentinoids into this more explicitly, because we framed the campaign particularly around opioids. But that chart earlier on about prescribing levels of opioids we could put that up for gabapentinoids and it's even more stark. So what we're very cautious of, we don't want a reduction in opioids with then the equivalent increase in gabapentinoids, and we're just shifting the problem elsewhere. The evidence base for the evidence base for harm from gabapentinoids isn't quite as mature as the evidence base for harm for opioids. But we know that they cause an increase in suicide risk. We know they cause an increase in violent behaviour because they're often abused along with opioids because they have an opioid sparing effect. So we want to make sure that we're capturing the full range of inappropriate pain prescribing. The next thing that we need to do, and it's one of the reasons why I'm here today, is to talk about that wider review of services and access and all the stuff that Victoria talked about. The services and the way the services are structured and the pathways and so on are not right at the moment, and they are over medicalizing, and we've got to find a way out of that. So one of the ways that I want to try and do that is to get opioid and gabapentinoid prescribing onto the ICS agenda. Obviously, the ICS is undergoing significant change and is going to become a much more important structure and organisation in the next 12 months. So I'm really keen that we take this opportunity to flag this issue up and get it on the agenda of the ICS, because I think if they view it as one of their top public health priorities, and I believe that they should, then that will open out lots more avenues. So as I said, we've tackled this from the prescribing point of view, and that's made some inroads, but that's only ever going to get us so far. We need to look at society, we need to look at expectations, culture, service provision, access, and it needs the whole health and social care system to come together to look at that. We're not going to tackle it just as a group of pharmacists or just as a group of physios or just as a group of secondary care clinicians. It needs to be something different. So I'll stop there. I see there's some questions in the chat box as well. So I'm not sure how you want me to do it, Victoria. Do you want me to just go through the questions that are there?
Oh, if you can do that, I've just picked up, there's just one from Nick there. What was the offer instead of opioids? If we take something away, we need to help clinicians have some viable alternatives. If you want to answer that one, I'll just have a quick scan through. I think that's the only question. A lot was just agreement with what you were saying.
Yeah, I absolutely, Nick, that's a very good point. And the simple answer to that was there wasn't enough as an alternative, because there isn't enough in the system at the moment, and access to those other things was hard before and has become even harder since since COVID hit, and a reduction in face-to-face appointments and so on. So it was really focused around reducing opioids, reducing problematic, particularly high-dose opioids. But to tackle it, we need to get away from the introduction of opioids as well. And if we're going to get away from the introduction of opioids, we do need to have better access to some of those other things. I'm hoping that we'll be able to use the hook of the new NICE guidance to leverage some of that, and particularly, again, if we can get it on the agenda at ICS level, then that gives us an opportunity to try and redesign some of those pathways and services.
That's, yeah, I think Elspeth's agreeing with you there. There's some really interesting research coming out around compassionate programs that get people back out into the community. Is it actually that the pain's the issue, or is it that's just a symptom of a bigger issue, and we need to knuckle down and find out, is it loneliness? Is it, you know, the bereaved? What is the issue, and can we signpost patients to those? And that's happening across the region to some degree, but does it need to be joined up a little bit more? I've got a few questions, because I always do. And then we'll ask the one from Callum there. You talked about diversion. Could you explain a little bit more? Is that when patients start on opioids but then do the more criminal type things?
No, no, it's where things that are prescribed for one patient end up with somebody else. So,
right.
So it's not unusual to find that you know, Granny is being prescribed some morphine, and actually the very helpful grandson or nephew or whatever comes into the house to help out a couple of times a week, and not all of the morphine remains in the house. So I think the latest figures I saw on that were from the National Crime Survey, and it said that between the ages of 18 to 65, I think it was, 7.5% of people have taken prescription painkillers, prescription pain medicine that were not prescribed for them. So that's a really, really high figure of people taking these things that have been introduced into the supply chain perfectly legitimately with the intention of being for one patient, but have been taken and sold or abused by somebody else.
That's really interesting. And the Painkillers Don't Exist program, it's on the internet, isn't it? Anybody can access it. You could we could be signposting patients to that now. It doesn't matter that it's local to Sunderland or Durham.
No, it doesn't. There are little sections on it that are Sunderland specific and Durham specific, and they refer to particular guidelines or resource packs or whatever bits and pieces. But it's completely open, and anybody can signpost. Anybody can signpost to it. Anyone can look at it. Absolutely.
Brilliant. And I think one more question, and then we'll have to move on. How can the traditional analgesic ladder approach in primary care be overcome, educated? I think that's a big question.
It's a big question, and it's a good question, because actually the traditional analgesic ladder is dead simple, and we all remember it, and it's quite straightforward, and it always gives you somewhere to go. You never reach the end of it, because you can just keep going up and up and up. And I think so there's something about access to other services and non-pharmacological interventions that go along with that. But also, I think the key to it is the patient expectation. If the expectation is that these pills will take away my pain, then if the pain's not gone, then I need more pills. The conversation right at the start needs to be, these pills will not take away your pain. These may help for a short period of time, these may help in a certain way, but they will bring their own problems, and there's a ceiling, there's a limit that we'll go to, and beyond that, there is no evidence that they will help. So I would rather see, there's a number of things I would like to see. I would like to see codeine not available for purchase over the counter in any shape or form, and it still is, because that allows people to self-medicate. I would like to see the traditional sort of open-ended maximum dose of opioids to be, you know, very clearly defined at a maximum of 120 milligrams and a maximum of 3 months, unless you're talking about cancer pain. And that's, you know, that to me is quite a shift from the traditional analgesic ladder that effectively has no ceiling to it.
Yeah, that's been really interesting. Thank you, Ewan. If we come up with any more questions, if we could post them to you, email you, that'd be great. Thank you so much for your time. That was fascinating. Thank you. So now we're going to move on to Sue from the Health Programme Manager for the Academic Health Science Network, and she's going to talk to us about the campaign to reduce opioid prescribing. And I'll watch out the chat for any questions you might have. Thank you.
Thank you very much, Vicky. And thank you to everybody for joining us on this lovely snowy sunny day. My name is Sue Hart. I'm a Health Programme Manager with the AHSN in the northeast and North Cumbria, and it's my absolute pleasure to manage the CROP project. So, flick on to the next slide, please, Vicky. What is CROP? Well, it stands for the Campaign to Reduce Opioid Prescribing. It is not a magic panacea. It's not going to cure this problem on its own. It is one tool in the toolbox of many to help to address the problem of overprescribing of opioids in our region. So what we've done is we've taken a piece of work that originated in West Yorkshire and we've adapted it to meet our own regional needs. So we're currently replicating this project across every practice in our STP bar about 6. So it's quite a big buy-in to this project. It's a collaborative piece of work. It involves us, the AHSN, all of the CCGs in our region and the medicines optimisation leads. It also involves NEX and it involves the West Yorkshire Research and Development team. It's a 12-month project. We're about halfway through it. And within that 12 months, we have committed to running bi-monthly data extractions from the clinical systems of each individual practice. And each data extraction is then translated into an individual practice report. So I'm going to talk a bit more about, give a little bit more detail about the practice reports in due course. But first of all, I wanted to just set the scene. I know Ewan's already done that fabulously for us. But if you just flick onto the next slide, please, Vicky. I wanted to start with a quote, and this quote has come from Margaret McCartney. It was published in an article in the BMJ entitled Honesty, Placebos and Pain Care in 2015, and I think this is quite thought-provoking. Margaret says, "We're encouraged to treat pain seriously and generously, but chronic pain differs from terminal care. How can we be sure about these drugs in the long term? And does the relentless political focus on the happy customer model of NHS delivery mean that doctors are less inclined to be unpopular by refusing to escalate or to continue doses of drugs that barely help?" So she asks the question, is the customer always right when it comes to high and sustained doses of drugs that have addictive qualities? So I guess you probably all think along those lines already. We have the next slide, please. So what are we talking about here? Well, when we're referring to opioids, we include medicines such as codeine, tramadol, and morphine. And we know that opioids are addictive for short-term pain, such as post-operative pain or trauma, and for cancer pains. But we also know that the safety and efficacy for chronic non-cancer pain is much less certain and can cause the problems of tolerance, dependence, and addiction. We also know that about 80% of patients who are taking opioids will experience at least one adverse effect from them. And we also know that there is international concern that patients are being moved onto stronger opioid doses without considering alternatives to medicines. Next slide. So I'm still setting the scene here a little bit. I'm quickly going to show you in the next 2 or 3 slides kind of a reinforcement of the problem that we have here. This slide demonstrates the rate of increase of prescriptions per patient per year over a 6-year period, and it pretty much speaks for itself. Next slide. This next slide shows prescribing rates of high-dose opioids. So that is the daily dose of greater than or equal to 120 milligrams of morphine equivalents per 1,000 patients over a 5-year period. You can see it's really clear that prescription rates are falling. So on the whole, we must be doing something right, yeah? Well, the problem is, the stark reality is that the thick blue line represents the national median. The thinner blue lines are the deciles, and the red line is our STP, it's our region. So while we're following the national trends, our rates are so much higher than national averages. We, in fact, sit on the 10th decile. So next slide, please, Vicky. And we've got a similar kind of picture here. This is the total daily dose of pregabalin and gabapentin per 1,000 patients. And this again shows rates rapidly increasing over a 5-year period. Again, we sit on the 10th decile, way above national average. Next slide, please. So what do our crop reports look like? Well, I guess the first thing to say is, to the eagle-eyed amongst you will note that these reports, these slides refer to reports from West Yorkshire. They were the only dummy reports that I could get hold of. So apologies for that. The format is very much the same. So the format is carefully designed. It's designed by an academic who has a specific interest in behavioural change. Page 1 is the introductory section. It's carefully worded in such a way that it's unlikely to prevent defensive reactions. And we also include quotes to provide credibility to the data. And I don't know whether you can read that, it's pretty small, but again, this is another powerful quote. It comes from a GP this time, and he says, "Doctors' prescriptions are killing people, and this is an international problem with rapid increases in opioid prescribing in Canada, Australia, Germany, and the UK. We could blame the marketing of Big Pharma, but the truth is these deaths are the responsibility of the doctors. We need to put it right." I think that's quite a hard message. Can we have the next slide, please? So this is page 2 of the report. This is the results page. Asks, how is your practice doing? And what it shows is easily interpretable data. It has a visual message and a summary message, both of which are closely linked. So whatever your preference for taking information in, I think we've kind of got it, visual or text, pictures or text. At the bottom of the page, there is a cohort table. I'm going to come back to that cohort table in a little bit more detail in just a mo. Can I have the next slide, please? So page 3, what next? This is the call to action page, and it consists of short, specific, actionable messages. Each practice is encouraged to develop their own action plan for what they're going to do based on the information they've been given within this report. Next slide, please. So back now to the cohort table that appeared in the results page. I just thought this was worth making slightly larger. Patients are stratified into risk cohorts. And the table shows the number of patients falling into each of the cohort. This table shows 8 different cohorts, but remembering that this was West Yorkshire's dummy report, we've actually got a 9th cohort in our reports that was put in at the request of clinicians, and that is the one that relates to gabapentinoid prescribing. Next slide, please. So really, just to summarise what the reports look like, they are not War and Peace. If they were War and Peace, the clinicians wouldn't have the time or the inclination to look at them. They are quite brief, but very succinct. In the table, we include tailored feedback for every practice. It has an action plan. It refers to NICE guidance, recent Cochrane reviews, any recently published evidence which supports the cause. And it also has any recent guidance which has been published from NHS England. We also include tips and hints to help with potentially difficult consultations. So next slide, please, Vicky. So I want to just finish my my presentation with the patient quote. The quotes I think are very valuable, and this one from a patient I found particularly valuable. Patient actually said to us, "I was taking opioid medication for many years. initially for pain, and then gradually over the time, they helped me when I was emotionally distressed. I used more to get the same effect and became physically and emotionally dependent. My life centered on tablets, and I lost all my interests. Since stopping the tablets, my sanity has been restored and my confidence has increased. I finally got my life back. I just want you to think about that and how powerful that actually is. The patient saying, I've got my life back since I stopped taking these tablets that I'd become addicted to. So I want to just summarize what I believe should be the take-home messages about opioid prescribing. So I think that opioid drugs can be prescribed to treat moderate to severe pain, but repeated use can lead to tolerance and dependence. This means that the user needs to take more and more of the drug to achieve the same effect. These drugs also have psychoactive effects, and many of the opioids are taken illicitly due to this high abuse potential. I think Ewan referred to that quite eloquently earlier on. We also know that half of all deaths which are related to drug poisoning involve an opioid drug. So we know it can be difficult to balance patient safety and patient pain management, but there is a lot that we can do to make sure that they're safe. Those of you who are prescribers, I really would urge you to think twice before prescribing opioid medication. And if you're not a prescriber, refer back to the prescriber in all cases where you think it's inappropriate. That's my take-home messages. Next slide, please, Vicky. That's me. Thank you. Happy to take any questions if there are some.
We've got one from Nick here, which is the reduced opioid reduction from general practice only? And do we know if there's an increase in prescribing in A&E and urgent care centres if patients can't get their access from primary care?
Mm-hmm. Mm-hmm. So I think what this does need is a very joined up approach, which is why Ewan is working hard to take the proposal to the ICS so that we can get something in place where everybody is singing from the same hymn sheet. We do need to have strategies in place for reducing the opiate medication. Can't just say to these patients, we're going to stop you. And there are very different approaches across the region. There is one practice in Northumberland who has simply written to all of their patients who are on high dose opiates and has said, we're going to start reducing you by 10% per prescription. If you've got any problems with that, and these are the reasons why, if you've got any problems with that, please get in touch. And of all of the patients, there were only 2 or 3 who actually got in touch, and the rest just accepted what was being done to them and went along with it. So as far as I know, he has no evidence that those patients are going elsewhere to secondary care to get their medication, and it's working for him. It's not an approach that everybody agrees with or is advocated across the region, but it's certainly working for some.
Yeah. Lindsay has just asked, how do we recognise inappropriate use? Now, as a physio, I'll give it a shot. I'll answer this one too, but tell me, because you know more than me. I don't think we can at the minute. I think this is an area that physios need help in. I wouldn't know inappropriate opioid use, but if I asked a patient, but we know we are really good at taking histories down, and I think the healthcare provision is missing a trick by not utilising us more, because we could easily have looked at that signpost back, start highlighting the issue, and is that where we get a more joined approach? I hope that would you say something similar, Sue?
Yeah, I would. And you know, as a physio, maybe it's not your decision to actually to make. Remember, you work as part of a team, and just to refer back for reassessment. I know the pain clinics do use a pain scoring system. And, you know, a lot of the patients who are referred in, they'll say, what's your pain score, 0 to 10? They say, oh, it's 10. and how do you feel on the medication that you're on? Terrible. I get all of these side effects and I have to take all of these other medications to counteract the side effects that I get. So the logical answer to that is, well, if your pain score is 10 is the worst it can possibly be. It can't get any worse if we reduce your medication, but what you may feel is a little bit better by reducing some of the side effects of that medication. And that's how some people deal with it. But I think, yeah, to recognizing whether it's appropriate or inappropriate is quite tough. It needs a good shared decision-making type conversation.
Yeah, absolutely. Thank you, Sue. Thank you so much. That was really interesting. We're going to move on to the next speaker, but if anyone has any more questions for Sue, put them in the chat and we'll post them after the event. All right, we're going to move on now to Cormac Ryan from Teesside University, another physio, and he's going to talk about the public health campaign, Flippin' Pain. Thank you, Cormac.
Hello, everybody. Next slide, please. So my name is Cormac Ryan. I'm Professor of Clinical Rehabilitation at Teesside University, but I'm also the Community Pain Champion for the Flippin' Pain campaign. Next slide, please. So you'll see a huge overlap between what I'm going to be talking about here and what we heard from Sue and Ewan. As you all know, pain is a huge problem. It affects 30 to 50% of people in the UK and accounts for approximately 30% of the disability in the UK. Next slide, please. Whilst clinical guidelines recommend over the past 30 years have changed from encouraging a biomedical approach towards encouraging a more biopsychosocial approach, that's not what we're seeing on the ground, as we've already heard. Actually, we're seeing an increase in a biomedical approach. We're seeing a 127% increase in opioid prescription in the past 10 to 15 years from Curtis. And over a similar time frame, we're seeing a doubling of surgical approaches for back pain. So why is this? Why are we seeing an increase in biomedical interventions despite guidelines recommending a more biopsychosocial approach? Well, that's multifaceted in terms of the answer to that question, but it is going to be a big, in part, and a huge part, the belief systems that exist within our society. The biomedical model is hugely dominant, and it influences pretty much everything we do from a healthcare perspective. And if you think about it, the interventions that are evidence-based, the biopsychosocial interventions, active physical and psychological therapies, they don't really fit into the biomedical model. If you've been told you've got facet joint degeneration, it's hard to see why exercise could be useful for you, what it could offer. And thus we need to tackle the public perception of the biomedical model, and we need to change it away from that biomedical understanding towards a more biopsychosocial understanding. Next slide, please. And one more click, please. And one more click. Thank you. So over the past 50 years or so, within the scientific community, huge leaps forward have been made in terms of understanding pain and getting a more a deeper understanding of how it works from a biopsychosocial perspective. But that information has not trickled through to the person on the street, and as such there are many myths and misunderstandings about persistent pain which act as a barrier to recovery. We believe that knowledge is the key to success. If we can take this scientific information and put it in the hands of those people who need it most, the public, the person on the street, the patient, the friend, the relative, the clinician at the coal face, then we can bust many of these myths and help people to become more health literate when it comes to pain, help them to make better, more informed choices about their care, put them in the driving seat so they're more likely to make evidence-based choices, such as choosing active physical and psychological therapies rather than the biomedical approaches that we've heard about already. Next slide, please. And that's something that they're trying to do down in Australia using the Pain Revolution, which is led by Professor Lorimer Moseley, a big proponent of pain education, where they're essentially doing public outreach programs and public engagement sessions where they cycle around the country and deliver engagement events that try and communicate this pain science message and try and shift people's understanding away from a biomedical approach towards a more biopsychosocial approach. Next slide, please. And we're trying to do that here in the UK through the Flip and Pain campaign, which is led by Connect Health and being delivered in conjunction with NHS clinical commissioning groups in Lincolnshire. Next slide, please. The aim of the Flip and Pain campaign is to change the way that people think about, talk about, and treat persistent pain. Next slide, please. And it's a collaboration of many, many people. So it's led by the campaign director, Richard Pell at Connect Health. Next, click through, please. Thank you. But it's also given by a range of people with pain. It's got a huge representation of people with pain. Click again, please. As well as a big representation of clinicians. Click again, please. Some artists, and click one more time, and the odd pain scientist and researcher. It's a huge team effort. Next slide, please. The campaign has 6 key messages that are simple and clear. Persistent pain is common and can affect anyone. Hurt does not always mean harm. Everything matters when it comes to pain. Medicines and surgeries are often not the answer. Understanding your pain can be key, and recovery is possible. Next slide, please. The campaign itself is multifaceted. We do a range of public engagement events. Back before the pandemic hit, we were doing obviously face-to-face talks in the bigger towns. And this we're centered or beginning in Lincolnshire, so these were in places like Lincoln and Boston, and the events tended to have a sort of a 45-minute didactic lecture style pain science presentation, followed by 45 minutes of Q&A with a panel made up of people with pain, clinicians, and sort of researchers, scientists. Next slide, please. The campaign also had or has a cycling Peloton tour component. So a bit like the Australian campaign, we were also going to reach out to more rural communities by cycling to them over sort of a week-long extravaganza and doing engagement events in those smaller local communities. Obviously, due to the pandemic, that made it more challenging to do this. We've had to put it off a number of times, but hopefully very, very soon we'll be in a position where we're able to run this. And whilst it will start in Lincolnshire, I really hope that it will progress to other communities and areas, including the Northeast. That the tour will be accompanied by a thing called the Brain Bus, which is a sort of an experiential learning part of the campaign, including things like virtual reality, illusions, infographics, etc., where people can get a better understanding of pain by experiencing perceptive illusions, etc., to basically get a first-hand understanding of the scientific information we're trying to convey. Next slide, please. Obviously, because of the pandemic, the online component of the campaign has grown considerably. So we have our website, www.flipandpain.co.uk, where there's a whole range of different resources, including real-life stories of people with pain and how getting a better understanding of their pain really flipped their approach to it. And those stories are exceptionally powerful and are a really strong component of the online campaign. But we've also begun doing a thing called the Flip and Pain Formula, which is a collection of infographics and animations and podcasts where people can access this information that was generally being delivered through the engagement events, but they can access it now from the comfort of their own homes to increase accessibility. Also, we've started running the engagement events themselves online as virtual sessions, and I'm going to talk a little bit more about those and some of the feedback we've had on them in the next slides. Next slide, please. So we haven't done a whole-scale evaluation yet. If anyone wants to give us a fat pile of cash to do that, we'd be delighted with that. But in the meantime, we're kind of doing a little bit more piecemeal feedback sessions. What I'm presenting here is some feedback we had from our last public virtual event, which was attended by 300 people from the community, predominantly people with pain. And this evaluation was a very, very simple approach. All the questionnaires were handed out after the event. The way the questions are asked might give the suggestion that it was before and after, but they're all after. Just need to be really clear on that. So you've got 7 questions here, all asking about sort of, I guess, people's approach and understanding of pain. If we look at the top one, the amount of pain is related to the amount of tissue damage. And obviously we want people to be understanding that pain isn't related to tissue damage, or that the relationship is very, very weak. We've got a series of similar questions, like asking, do you think an MRI is needed for everyone with pain? Do you think people with pain should be active, etc.? In terms of interpreting the graph there, the easiest way to think about it is, if you remember Strike It Lucky, what's a hot spot? It's not a good spot. Generally, the red is bad and the blue is good, with the exception of the second question where that's reversed. So people were asked, before you had attended this event, how would you have answered these questions? And that's how they would have answered these questions. Now, next slide, please. Next click. And this is how then they were asked, and now, having had this event, how would you answer them? And what we see is a nice little shift to the right, an increase in blue, and a positive shift of people's understandings, a more biopsychosocial understanding of pain. Just what we wanted to see. Next slide, please. We also asked for some qualitative feedback. Next click, please. And this is just some of the things that people have said. So the talk was delivered at just the right pace, at an entertaining way, with the perfect balance of information for health professionals and the general public. Click again, please. The timing and informal approach worked really well to keep it accessible for everyone. Next click. I have previously attended my local pain management services who have tried to explain some of the things discussed, but somehow it seemed to click more this time. Next click, please. I really liked the range of people on the panel, and Cormac is a handsome devil. Has he lost weight recently? Next click, please. Excellent. Plus, the recognition that chronic pain is real, even if we need to flip how we think about it. It also helped to hear from someone who has been through the process. It was engaging all the way through, and that's hugely, hugely important. People with pain are central to the campaign and central to all the messaging, and that I think is what really clicks with the people who attend. Next slide, please. Finally, I just want to give some feedback on our clinician-focused event. So we're trying to also reach out to people, clinicians at the coalface as part of the campaign. So this event we ran virtually, I think about 2 weeks ago now. We had over 3,000 clinicians at this event. It was hugely well attended, with a variety of different healthcare professionals. And we are doing some quantitative analysis of people's beliefs, but we're doing that as part of a more robust research study, and hopefully data will come from that in time. But here's just some of the more informal qualitative feedback that we've received. So I'm a clinical psychologist working in chronic pain, and I'm relatively new to the specialism. I just wanted to thank you for making something highly engaging, having a team who were highly enthusiastic and had clearly thought a lot about how to make it appealing to the audience. Made it a pleasure to watch. Would gladly watch any more you're doing in the future. Next click, please. As an acupuncturist and massage therapist, I would like to believe that I'm shifting my practice more to a biopsychosocial model. Yesterday's webinar was awesome, hearing firsthand from the healthcare team, the scientist, and even better, the client. I am wondering if I can share the recording of the webinar with my fellow colleagues. I am the coordinator for the massage therapist community-based network meeting. I believe it would be valuable. Next slide, please. So yeah, overall, this is kind of the footprint of the campaign. We've had 6 live events over the past sort of 18-month period. We've had almost 6,000 delegates. We've been working with 2 different charities, almost 5,000 people on our mailing list, 10,000 website views. We've presented at conferences. We've got some social media followers. We've done some local radio. The outreach tour, Peloton tour, will eventually happen, no doubt. Next slide, please. And here are some of the groups that have either endorsed us or have given us some support, or we have worked with in some way. A lot of really good groups to be involved with, and I think adds weight and strength to the campaign. Next slide, please. And that's pretty much it. Thanks for listening.
Thank you, Cormac. That was great. And I think you have lost weight recently, haven't you?
Very kind of you to say. I don't know who put that in. I guess it might have been my mother.
Let's have a look at the questions come up. Let me see, Joshua. How do you get clinicians on board who have vested interest in biomedical treatment approaches to get a consistent message across to patients?
Well, I think reaching out to clinicians is absolutely crucial, and that's why we're not just reaching out to, I guess, we're not just doing public events, we're doing clinician-focused events as well. And whilst there may well be, I guess, clinicians who have an ulterior motive, I think the vast majority just want to help their patients and are doing what they think is the right and appropriate thing to do, because many of them will have very biomedical understanding because of their training. You mentioned it already in terms of how people are trained, and a sort of how many of us will have grown up in a sort of a biomedical training approach, and that influences the care that we give. If we can begin to shift the understanding and viewpoint of clinicians towards a more biopsychosocial approach, then we can make a change in how we manage. Now, I'm not saying that happens overnight. That's a very slow process. But I think there's been, for example, the Lancet back pain series group with people like Buckbinder and Foster, etc. Recommended that a public health approach that tries to communicate key messages, such as we're doing here in the Flippin' Pain campaign, is essential to trying to turn the ocean liner. I think Ewan used that metaphor as a really nice one, towards in the right direction, away from the outdated and ineffective biomedical strategy.
Yeah. I think that's completely right. I think we need to move on because we're running out of time, and I do want to give you all a comfort break. Any more questions that come through, I will pass them on to Cormac. Thanks, Cormac. That was great. Thank you.
Thanks, guys. Bye-bye.
Right, let's move on. We've got Professor Mike Hurley here from the Health Innovation Network of South London, talking about Escape Pain Back Programme and the Joint Pain Advisor role. Thank you, Mike.
Hi, thank you, Vicky. I'd love to be up there. I love the Northeast, but unfortunately we're all stuck at home. So it's lovely to be able to talk to you. First slide, please. And sorry, the next one. I'll probably flick through the first few slides very quickly because they're kind of there to insult your intelligence. I'm sure you all know the problem that we are facing here. 9 million people with chronic hip knee pain, 10 million people with persistent back pain. And the problem is getting worse because we're all doing less and less apart from eating more and more. And we know inactivity and obesity increase the prevalence of joint pain. And of course, now the whole thing exacerbated by the pandemic, when people have been locked down at home and inactive for so long. Next slide. Thank you. The impact on individuals is enormous, affects all domains of people's lives, and can become quite crushing. One of the things that's been fairly hidden is actually the impact on work as well. And you can see from those figures that it's an enormous socio-economic problem there. People have to reduce their hours, they have to retire early. It's the second highest cause of lost working days after the common cold. And again, it's getting worse as more people are suffering musculoskeletal problems. So to a nation, it's costing us an enormous amount of money. Next slide, please. It's normally managed in primary care by GPs. They struggle, they're overwhelmed with the numbers before. It's getting worse now, of course. Underwhelmed by the condition when they have so many other urgent things to think about and to treat. Benign chronic joint pain doesn't always ring their bells. So that it's treated with drugs, in eventually maybe surgery for people. The GPs themselves lack the time, the training and the skills to actually help people to understand their problem and how they can help themselves. And nice core recommendations are that people should be self-managing themselves and adopting healthier lifestyles, increased physical activity, losing a bit of weight to actually start to control this problem. But it needs time to do that. We have millions of people to get to. How on earth are we going to do that? It also medicalises a problem that people actually consider part of their everyday lives. Pain is part of our everyday life, and we have to learn to live with it and cope with it rather than defeat it in some sort of way. Next slide. So that's where our escape pain comes from. Sorry, that banner shouldn't be there, but escape pain is a program where people come up twice a week in groups of about 10. It integrates information, simple information, given to people about their problems and how they can cope with it, with a supervised, challenging exercise program. And over the course of the 6 weeks, people learn what they can do. They learn that they can actually start to control their symptoms. It decreases their poor health beliefs, improves good behaviours, particularly physical activity, and they learn that they can change the course of the condition. It was just been awarded the HSJ MSK Care Initiative of the Year, and I put that up there not as because we're all on ego trips, but really to acknowledge the fantastic work that the MSK program at the Health Innovation Network do to push this program there, and are supported by Vicky in the northeast, and also Karen Oliver in the northwest of England. So thank you to them all. But we were pushed because most of this has looked at people with hip and knee pain. Could it be used for people with back pain? And that's what we did a few years ago. Next slide, please. We adapted the content of the program for people with back pain and ran a pilot study in South London, where we recruited nearly 300 participants to it, onto the program. 75% of them attend about 75% of the program, so attendance is good and attrition low. And there were significant improvements in the outcomes that we were measuring. Those were number of days in the past week active for more than 30 minutes. You can see we increased that by 1 day a week. Sit to stands, how many can you do in 30 seconds, which is an indication of disability and future disability. And again, we increased that. And also the MSKHQ, which is developed by Versus Arthritis and is pushed by the Charter Society of Physiotherapy. And you can see that we're increasing that outcome by over 9 points, which is a significant amount and clinically significant. So people are reporting less pain, better function and better psychosocial function after they've been through escape pain for backs. Next slide. When you ask why and how do they feel about it, nearly everybody says that they welcomed the program and would recommend it to others because they felt benefit, less pain, more able to do things. They understood their problem, They learned how they could self-manage it themselves. It improved their general well-being, and again, that's sometimes as important, more important than pain. The fact that they are worried and it's interfering and controlling their lives, they are starting to be put back in control of their lives. And they actually like the kind of interaction with facilitators and also the group. So this peer support where they can ask questions, where they can learn from each other is enormously supportive. Next slide. So we can say for escape pain for backs, it can be done, it's feasible, we can deliver it. It improves people's physical, mental and social health and well-being, helps them understand to self-manage their condition, and we can start to deliver it in the community because we've started to deliver it recently in leisure centres. 2020 was the year where we were really going to start pushing escape pain for backs in the NHS and community centres. The virus stepped in, and lots of the face-to-face classes have shut down initially, stuttered back to life, and have been shut down again. But we are hoping that the recovery will start again in the spring, and we'll be able to get escape pain for backs out there again. But escape pain is an intensive program, and one of the things that we realise is that we have to get to millions of people, and it's going to be very difficult to get to use escape pain, and escape pain isn't appropriate for everybody. So next slide. We developed a program called Joint Pain Advice. Next slide. Which essentially is how we work with people to make them aware of their problems, how they can help themselves in very simple ways, and support them to actually start to make those behavioural changes. So we educate them about their problems. We start to use behavioural change techniques to push them along that line to change, work with them to develop a personalised care plan, which particularly focuses on the benefits of losing a bit of weight, having a healthy diet, increasing your physical activity. And we signpost people to what's happening in their community, rather than doing a supervised exercise program as with escape pain. We say, what would you like to do? Is it swimming? Is it cycling? Is it dancing? And this is happening in your particular community. So we don't want to reinvent the wheel here. Next slide, please. And the pathway is that they have an initial assessment of their physical activity, their ability, their pain. We start working with them to agree goals, give them targeted advice, and develop an action plan. And then over 4 sessions for up to 6 months, we start to review those outcomes, review those targeted advice, change them if necessary, but start to help people to see how they can actually start to achieve what they want to achieve, and therefore less pain. Next slide. We delivered it in physios in primary care in Lewisham in South London. We've also delivered it using health trainers who are deeply embedded in the community in Greenwich in South London, and found in both of those that there were improvements in function, reductions in pain, and improvement in people's health and well-being again. And a return on investment of £4 for every pound that's invested. Next slide, please. But what we wanted to do is see if we could actually deliver it in the workplace as well. So this is a study that we've just completed with the Department of Work and Pensions. We looked at employers, 8 large public organisations and 12 small and medium enterprises in London and Cornwall. In each of those places, trained 2 or 3 people to deliver joint pain in the workplace. That could be somebody who was based in that workplace, or there were a couple of places where they had joint pain advisors who toured around a couple of the partners. Very broad inclusion criteria to welcome people onto the programme. Next slide. You can see that we had nearly 500 people there, mean age 49, a range of pain in various places, back predominantly, knees, back, knees and hips, so a whole sort of mix of what people were presenting with. Next slide. What we found was that as we went through the service, people dropped out, and I'm not going to cover that up. I'm going to come back to it eventually. Next slide. And again, please. And again. What you can see were there are improvements in virtually all the outcome measures that we were looking at. So pain decreased, function improved. Next slide. People's self-confidence improved. That resulted in a small decrease in work absenteeism. And next slide, and a small decrease in the number of GP consultations. Next slide. We also found that in the 6 months prior to JPA and then the 6 months afterwards, next slide, you can see that there were less investigations, consultations after people had been through JPA. And again, next slide. And they were having, sorry, it's off skew a bit. They were having, as I say, less investigations, consultations, and interventions. Next slide. So for a modest amount, we worked it out to be about £62 per employee. People had better physical and mental functioning. They take off one less sick day, less GP appointments, fewer investigations, and fewer medications with the attendant side effects. And next slide. When we asked people, they're very, again, satisfied with it because it worked and it was helping them. They understood their problems like escape pain. They're more confident about managing it themselves. They liked the longer, better consultations that they saw tailored to their own personal needs. And they like the positive message that, yeah, MSK is a problem. And even if it can't be cured, it can actually be managed. And you can link in what's happening in their workplaces or community so that they can actually start to help themselves. Next slide. As I said, what you find as you go through that is people start to drop out. Now, part of that is because they were expecting something else than what JP was offering. So we need to give them better information about what they're going to get to retain some of those. Some of them saw it as not a priority. They had other problems in their lives that were more important. And this is an intervention that does require time and effort, and they weren't prepared to give that time and effort. But many of them said, actually, I've had I got enough information from the first 1 or 2 sessions with you, so I don't think I need any more advice. I can use what you've got to actually start to manage my problem better. So the attrition is not necessarily a sign of failure. It may be a sign that people are starting to self-manage their problem or more and saying, actually, I don't need you anymore. I can cope with it myself. Next slide. So to conclude, JPA gives people the nice advice in their work places. Large employees or small, medium-sized enterprises can actually start to deliver it. It's safe, it's beneficial, it's relatively inexpensive and avoids turning people into patients. We need a bit more information about how it actually reduces healthcare utilisation and also about people's absenteeism from work. Next slide. And it's been given by lots of different people in lots of different places. So it's something that can be really started to roll out there so that the enormous numbers of people with joint pain can be helped. And next slide. So both of our interventions, escape pain and joint pain advice, we would argue is safe, effective and doable. It starts to demedicalise this problem by helping people to self-manage and cope better themselves, more popular certainly than the drugs that they don't like, and it improves people's quality of care, access to care, and to some extent their healthcare utilisation. So thank you very much, and happy to take a few questions if there are some, Vicky.
Thank you. Does anyone have any questions? Because while you're thinking of them, I've got a few. I'll let you think. I'm coming back to some. I'm really interested in the joint pain advisor role. Is that it's workplace, but what are the qualifications to become a joint pain advisor? Could it just be somebody who's on the payroll in that place?
It could be. We've talked about sort of workplace, MSK workplace champions, like you have, health and safety or fire, something like that. It doesn't need. You don't need to be certainly not medically qualified or an allied health professional. You need to have a certain amount of enthusiasm for it and empathy with somebody. And we give them a half-day training course. Just tell them basically about MSK problems in a very broad way, and by and large that is not to give them in-depth knowledge, but really to break down their own lack of confidence in telling someone who is sometimes a bit old and in pain to get up and exercise, because it's counterintuitive to what people might be expected to be told to do, really.
Yeah, thank you. And I think, well, one more question, two more questions. Are the how much is the training? So if somebody was going to go away and do the joint pain advisor role or the escape pain back role, how much is the training?
The joint pain advice, it's £100 for the half-day training course.
Is that virtual? Sorry, is that virtual?
Well, it used to be, but it is now. Everything's virtual now, and it's one thing the pandemic is good for is bumping lots of us into doing things that we were fighting shy of. Now it's more or less online, so we can get to more people over the country. Same for escape pain. A lot of it is now delivered online. The training and the training for that is about £250.
Thank you. Nick's asked, how effective are online escape options?
We're assessing them. The effectiveness of this is very often, and the people report back to us, because of this interaction they can have with the facilitator and particularly with each other. So I've always thought that it's not as effective, and I don't think it is as effective as the face-to-face programs. That said, the early indications we've had by the virtual delivery of the program that we've achieved during the pandemic has actually showed that it's more effective than I thought it was. Again, we're probably sweeping up the people who are the enthusiasts, if you like, there's all sorts of problems with people's ability to get online, to stay online, and all that. So I think they are effective, more effective than I thought they were going to be, but I would say over a period of time, maybe not as effective as the face-to-face programs. Excuse me.
Brilliant. Let me see what, brilliant. I think that's all the questions we've got time for now. If we're getting more through, if I come back to you, and thanks, Mike, that's great. I'll signpost anybody down towards you. So Absolutely. Is it the hello@escape-pain is the best email to inquire? Yep. So there's the hello@escape-pain, but I can send that out within in the final response when we send everything out. So we'll send that out to everybody. Thank you so much. You don't want to be up here at the minute. It's covered in snow and it's very cold.
Same here. We've got you pass it down to us, freezing down here.
Oh, lovely. Yes. Oh well, go and enjoy. Get some sledging in. Thank you so much. Good to see you. Bye now. Right. So now we can move on to Esther Williamson, who is going to speak to us about cognitive behavioural skills to treat back pain, the Back Skills Training Programme, and she's from Oxford University. Welcome, Esther. Thank you so much for agreeing to speak to us.
You're welcome. It's great to be here today, Victoria. So I'm going to be talking about the cognitive behavioural skills training programme that was developed by our team and evaluated first in a clinical trial, and then we've recently finished an implementation study. Next slide, please. Next one, please. So this has been a piece of work that really has been going on for about 15 years now. So I'm obviously presenting on behalf of a large team that has been involved in this work. This is just some of our past and present best implementation team. And we've had substantial investment from the National Institute of Health Research to do this work. Next slide, please. So I won't dwell very much on this because you're all well aware of the problem that we're talking about. But I think what has really struck me as we've been, as I've been listening to the talks this afternoon and the questions, is about this real need to find alternative options for patients that don't involve medication, and that there is a real need for us to have effective treatments that people can be given as an option if, if the drugs don't work. Next slide, please. So you'll all be aware that part of NICE guidelines, the recommendations are to consider psychological therapies, using a cognitive behavioural approach for managing low back pain, and that it should be part of a treatment package rather than just being provided in isolation. Next slide, please. If we look at the gap between treatments for which there's evidence of effectiveness and what's actually being delivered in clinical care, then there really is a need for better provision of these combined psychological and physical treatment programs. And this has been identified as the largest gap in the UK spinal services. So the BackSkills training program offers a clinically effective and cost-effective way to deliver a combined psychological and physical treatment to patients with persistent back pain. And I think obviously it's good to have lots of different options for different patients. So it's really today I'm just going to talk you through a little bit about the program as an option that could be considered to be delivered on your patch. Next slide, please. So a cognitive behavioural approach combines the cognitive and behavioural psychological models of pain. And it's based on the understanding that there is an association between thoughts, feelings and behaviours. And in the BEST program, the CB approach is applied to back pain. So we know that back pain can lead to unhelpful thinking, such as hurt equals harm, so that when patients experience pain, they equate this with tissue damage. And we know that these thoughts will influence how a person acts and how they feel. Next slide, please. So the aims of the BEST program are really to help patients sort of undo unhelpful beliefs that they may have about back pain. But as well as that, it's about providing skills and motivation so that patients can become more active despite having ongoing pain. So it focuses on reevaluating thinking and reducing the use of passive coping strategies such as rest and avoidance, taking medication, and really promotes healthful behavioural responses such as using pacing to return to activity. Next slide, please. So the BEST program consists of an initial one-to-one session, which takes around 60 minutes. This is a clinical assessment, but it's really important also during this session that you do the goal setting for what the patient wants to get out of the program, but also the home exercises. So exercises are a key component of the program as well, although most of the group is dedicated to the cognitive behavioural approach. The patient then comes to group sessions, 6 group sessions that take about 90 minutes. And then they cover different topics around understanding pain, overcoming unhelpful thoughts and behaviours, teaching skills such as baseline setting and pacing, the role of exercise in back pain, and techniques such as relaxation to help them manage stress and pain. When you deliver the BEST program, it is a very structured format. And actually, there's a manual that can be used then to deliver this, and sheets that give you prompts for all the discussion. So actually, if people are new to cognitive behavioural approaches, this is a really nice way to start, because actually it is a very structured and manualised program. So that allows people then to build their confidence in using this approach with patients. Each week follows a set structure, which covers all the core elements, and including homework, which is part of a cognitive behavioural approach. Next slide, please. So the exercises are an important element of the program, remembering that NICE guidance is for a combined physical and psychological approach. So it's important that the exercises are reviewed during the group sessions. So generally there's a gap, a break within the group where they can then review exercises as needed, and increasing physical activity is a key focus of the groups. Next slide, please. So does the BEST program work? So this was tested in a large clinical trial, which was conducted at the University of Warwick. Sally Lamb was the chief investigator, and there was 700 participants in the trial, and 2/3 of them
Sarah, it looks like we're having a few technical difficulties here.
Oh, okay. Can people hear me? Is there a problem? No.
Yeah, I can hear you. Tori, you okay?
Okay, sorry, I just heard someone saying there was technical problems, but I'm not sure if that was directed at me or not. Okay, I'll just continue. So there was, just over 700 participants in the trial, with 2/3 of them receiving the BackSkills training program, with the primary outcome being the Rollins and Morris Disability Questionnaire. And we also measured pain using the modified von Korff at 12 months follow-up. Next slide, please. So the primary outcome, we had 85% follow-up at 12 months. And there was both clinically and statistically significant differences in disability at 12 months in those that received the cognitive behavioural approach compared to usual care. And we also saw improvements in pain, fear avoidance, self-efficacy, and quality of life in those receiving the cognitive behavioural approach. And when we looked at the impact of group attendance, we did find that there was a relationship there, so that the people that attended more groups did tend to have better outcomes. Next slide, please. So the intervention was clinically effective, improving its function at 12 months. We also went on and did a longer term follow-up at just around 3 years. And actually what we found was that the effects were maintained at this long-term follow-up. And that's actually quite rare. Often what we see in these types of clinical trials is people improve, quite close to that point where they've had the treatment, then actually over time their symptoms revert back. So actually it was really encouraging to see that these changes are maintained. The intervention is also cost effective. If we look at the complete healthcare costs over a year for those that receive the best program, they are, certainly less than a package of physiotherapy for low back pain. These costs actually were done quite a long time ago, so they may be a little bit out of date now. Next slide, please. So during the trial, the therapists were trained to deliver the intervention in 2 days of face-to-face training. But if we were to facilitate widespread implementation of the best program, then we needed a way to train clinicians that was both scalable but also easily accessible. So our solution was to develop an online training program to teach health professionals to deliver the best program, and really to just make it as accessible to as many people as possible, and to facilitate implementation into clinical care. So the initial version of the training was developed by Helen Richmond as part of her PhD. And we then went on to enhance, on the back of her work that she did, we then enhanced the training, and that was launched in March 2016. Next slide, please. Oh, sorry, that's not so clear, that slide. So we had some funding from the Oxford Clark and the National Institute of Health Research to carry out an evaluation of the implementation of the BEST program, using an online training strategy, but also collecting clinical outcomes. So we ended up training just under 600 clinicians, completed the training from 101 NHS trusts, and we then went on to carry out a service evaluation in 34 physio departments across 21 trusts. We ran 160 BEST groups as part of this implementation study, and 923 patients attended the program. Next slide, please. So in terms of the training and how effective it was, we found that the majority of people, 98% of people who completed the training, actually felt that they were confident in their ability to implement the program. But what we also found was that only 52% felt confident in their capability to implement the program. So the first one was really about their personal ability to deliver the group. The second one is about their capability to implement it within their department. And I'll talk about some of the barriers that were proposed. And then around 57% then who completed the training intended to implement the program. At 6 months follow-up, we found that around a third of people who responded to this had actually gone on to run the group within their trusts, and it was being delivered in 27 NHS trusts. So at a couple of points throughout the study, we asked about potential barriers and then actual barriers. And this is what we found here, was that sometimes there was concerns over lack of suitable patients, and this often may be more around the person running the group's perceptions, or the physios or clinicians' perceptions around what patients want out of treatment, and actually deciding whether or not they felt that their patients would suit a cognitive behavioural approach. And once again, we get this issue of patient dropout and perhaps reluctance to attend. And this, I guess, fits in with the discussions we've been having about patient expectations and about a sort of paradigm shift in how we think about managing back pain as well. Sometimes space to run the groups could be a problem. But the other issue that came up was just around sort of time and capacity to actually introduce change within the department. And especially if there was lack of managerial and organisational support, this could be a problem. And then sometimes the funding models didn't really suit delivering group interventions either, because it actually meant that the department missed out on funding if they delivered treatment in a group rather than one-to-one. Next slide, please. So we wanted to know if we got the same results when we delivered the BEST program as part of routine clinical care as we did in the main trial. So alongside the training, we invited people to take part in a service evaluation and asked them to collect clinical outcomes. So you can see that we also had a bit of dropout as we went through the study. We were relying on busy clinicians to collect data at some points in the study, and then at other points we used postal questionnaires. So for the pain, we saw slightly smaller reductions in pain at around a mean change of 1 point on the VAS. But we saw very similar changes in function to what we found in the main trial. These were 2-point change on the 10-point scale, which would be considered a clinically meaningful change. Patient satisfaction was very high with the program, and the majority of patients were satisfied with the service that was provided to them. And as the main focus on the BEST program really is about improving function rather than reducing pain, we were happy that this was a successful translation from a clinical trial into clinical practice. Next slide, please. So the training has now moved to the Future Learn platform, where it is currently available. So it's been there since February 2019. It's freely available. It's now run through the University of Exeter, where we're developing a library of courses related to rehabilitation interventions. So far, we've had about 3,500 people complete the course worldwide. It's structured as a 6-week course, but actually the whole course is available on the day the course starts. So you are able to complete it in a single day, which we often find people find more convenient to do than doing it over a longer period. Next slide, please. So these are the sorts of questions that we get asked in terms of the BEST program. So the first thing is just what is needed to actually to deliver the BEST program within your department. We would advise that you complete the training, mainly because you can get all the materials then that you need to run the course. The manuals there, all the crib sheets for running the sessions, and all the patient materials are all downloadable within the course. The main thing that we found that people need to actually deliver the program is really support from senior staff and management. So what we found in some of the work we did, particularly in Helen Richmond's PhD work, was that when less junior staff did the training and they didn't have the support of more senior staff, it was almost impossible for them to implement the program in clinical practice. And this was often around getting either changes sort of within diaries and, you know, how departments were operated, but also getting more senior staff to actually refer people into the program was difficult. And this was, I think, once again, related back to that paradigm shift. In terms of equipment and space, you don't need a great deal. You need a place seating for patients, you know, up to 10 patients could be in a group, a flip chart or a whiteboard where you can write the sort of session topics and do the interactive discussions, and then also just a space where you can check the exercises. Next slide, please. Often we get asked how you select patients to take part in the BEST program and whether they should be using something like StartBack to identify people. So StartBack didn't exist when we ran the trial, but actually we found that the program is suitable really for anyone that's got persistent back pain. From the analysis of our data, we haven't found any specific groups that respond better to others. And we have done a little bit of work trying to sort of retrospectively match StartBack to the data, and we didn't actually find that there was a great match with any of the groups, and the outcomes that benefit was equal across the whole groups. In terms of how many people in the group, we recommend about 6 patients is a good number of people so that you get interaction and sharing of experiences. But usually we find that sites tend to book a few more in to make sure that you've always got numbers. I think someone else I saw in the chat had mentioned about dropout being a problem, because we are asking people to commit quite a lot of time to coming to this group as well. Next slide, please. Is the one-to-one session necessary is often asked, but actually this is really important. It builds rapport. It starts you off identifying the sort of issues that you may need to address in the group with that individual. And it's really important that you do your home exercise with the program and also set their goals. We also often get asked, can you adapt the program? In terms of effectiveness, we can only say that we know it works in the format that we tested it in the trial and in our implementation study. But we know that sites have been adapting the program. This is sometimes adapting the number of weeks it's delivered over. So they might do slightly longer sessions, but only have 3 of them. They might add an exercise session to the end of the class. They've adapted the exercises to make it more specific spinal exercises. The exercises that are included in the program are quite functional, or sometimes they've expanded it to include people with cervical and thoracic back pain as well. The one thing I would say about that is I think whatever adaptations you want to make, it's really important that that the same message is given to patients, and that you're not sort of switching between a sort of biopsychosocial approach and, then going back to a biomedical approach. But actually, if there's exercises and things involved, they need to be carried out with the same ethos. Next slide, please. We sometimes get asked if it should be only experienced therapists running the group, and I would say no to that. More experienced staff might be more confident to deliver the program, but actually we haven't seen any difference in effectiveness based on the grade of staff delivering it. Some departments have considered supporting less experienced staff, during their first group, and maybe buddying them up with a more experienced staff member. But I think the key thing really is that staff need to be enthusiastic about using a cognitive behavioural approach. So if a person is not bought into that approach and they don't agree with the cognitive behavioural approach, then they're probably not the right person to be running the group either, because what we really don't want is patients getting mixed messages. Next slide, please. And then the most frequent question that we've had really over recent months has really, can we run these groups online? So I do know that some sites are running groups online using platforms such as Teams. And we've provided them with a deck of PowerPoint slides that have the main discussion points and some of the diagrams like the fear avoidance cycle and things on them. One site in particular, Cambridge Community, has been running the BEST program now for several months. They've run around 9 groups so far. And Hannah, who has been running these groups, has been in touch with me and given me some feedback on that. So they found that they did need to adapt the exercises to make them easier to demonstrate online. That as part of that one-to-one session, they need to talk people through how they're going to access the course online. And then they've sent out the patient workbooks prior to the group. And I think she's also said that they sometimes had to offer telephone calls as well if people had difficulty with accessing it. But actually that has run reasonably well online, which they're continuing to do at the moment. Next slide, please. And I'm just going to end with a quote, really. So this was feedback from a patient that came back on one of their evaluation forms that they sent back to us as part of the service evaluation that we carried out looking at the implementation. And I'll just leave you to read that there. Next slide, please. So thank you for listening. And I think if you are interested in doing the training, that's the link, and I'll post the link in the chat as well. So the next course will be available from next week. It's not there at the moment, but if you go to that link, you can put your email in and you'll get an email when it is released. I just had to sort out a few things, which I'm doing tomorrow. So I was hoping to have it done by today, but I didn't manage it. But it will be up there from next week, available if you would like to do the training, or if you need to get in touch, then there's my email as well. And I'm certainly happy to answer any questions. Thank you.
Lovely. Thank you so much, Esther. That was great. Mike's come back to say that your experience seemed to really mirror those really closely, and he doesn't see escape pain and BEST as competitors. The problem with back pain is big enough for us all to be needed to help out, and I think I quite agree. It's just so frustrating that so few people can access these programs and get meds, etc., first line treatment. And we've got one, I don't know if it's Callum Miles or Miles Callum. We're looking to partner with another trust to do online delivery. Who could we contact? Materials could be provided. So could I put you two in contact with each other?
Yes, certainly. So we have a slide deck that we've put together that people are welcome to use and edit. I mean, we're just happy for people, to use it, because we just think it's such an important thing. And really, what Mike was saying was that I certainly don't see them as, competing programs. I think they're just different options. And I think you have to look at your service and see what is best for you to implement. And sometimes it might be that one is more suited to another. If you don't have a great deal of space for exercise, then actually BEST is great, because actually it is just a room, that you need, rather than sort of any equipment or exercise space. So, there's pros and cons for both of them. And yeah. I just think it's looking at what fits your service.